Thank you very much. So I want to thank the organizers for the opportunity to be here again for my fourth visit to this beautiful, hospitable city. And yes, I am Polish. My father was born here in Poland, as you well know. I'm a first-generation American. So it's always a pleasure to come back to my father's homeland. So we're going to talk about frontline therapy in multiple myeloma. My colleagues are going to talk about relapse disease. I've got a list here of what we're going to talk about as far as pertinent topics for the audience to which I'm speaking. Because in the United States, we have the opportunity to treat patients a little bit different because of the availability of drugs, which you don't have here in Poland. So we're going to talk, first of all, about VCD versus VTD, which is a European trial, VRD versus RD, which is a U.S. trial, a phase 2 trial that was done here in Europe regarding induction therapy. We're going to discuss should we have transplants and when we have when they should be transplanted. I want to talk about minimal residual disease, which is one of the hottest topics in the area of myeloma. And then Dr. Ludwig was already talked a bit about high-risk disease. I'm not going to repeat what he said, but I've got a couple of things I'd like to add about high-risk disease, particularly a paper that just came out in the last few months. So this is generally the schema that we utilize to treat patients with multiple myeloma. They get induction therapy. If they're transplant candidates, they get consolidated with high-dose melphalan. And then, as Dr. Ludwig already alluded to, the general consensus is to use some type of maintenance therapy. In contrast, for those patients who are not transplant eligible, they get whatever their initial therapy is, and they usually continue on that therapy indefinitely, although there may be some changes in their schedule or dosing of that schedule. Depends on which trial you want to use. If you want to use the Italian trial by Palumbo, they use just lenalidomide alone in his trial. If you want to do the first trial by Ben Bowker, they used lenalidomide and dexamethasone continuously. I don't know which one's the best, to be honest with you. Maybe we could ask Dr. Ludwig later. But this is generally the schema. We have a whole variety of new treatments that we didn't have back when I first started doing multiple myeloma over 25 years ago. We were just giving vincristine, adriamycin, dexamethasone, or just high-dose dexamethasone. We now have a whole list of immunomodulatory drugs and proteasome inhibitors that can be used for frontline therapy. Standard of care, which I hope to prove to you, is still consolidation with transplant. And then there's this issue of maintenance therapy, or consolidation therapy, which is also one of the hot topics, both in the U.S. and in Europe. And finally, one of my colleagues is going to talk about relapse. So when you deal with induction therapy, the first decision you have to make is, are the patients transplant candidates? And briefly, because I assume most of the individuals in this room probably have in their minds what they consider to be a transplant candidate, it differs in Europe than it does in the U.S. In the United States, our socialized medical care system, Medicare, doesn't have an upper age limit for transplant. So in our particular center, which I didn't introduce myself properly, I'm a myeloma doctor, but I'm also one of the transplant team. So in our center, we will actually transplant patients up to the age 80 if they're in reasonable physiologic condition. In Europe, it's usually cut off either at 65, although there are some countries that have now extended that to 70 years of age. So they have to have certain organ function. Age is really not a priority when you consider a transplant. So they have, usually it doesn't require 6 cycles of induction therapy. Actually, you can get by sometimes as few as 2 cycles of induction therapy, but 2 to 4 would be the most likely number of induction cycles, collect their cells, transplant, consolidation therapy, and then maintenance therapy. So we have a number of trials comparing different frontline therapies. We have VRD versus RD, which is bortezomib, lenalidomide, dexamethasone, the U.S. intergroup trial led by SWOG, showing that VRD compared to RD, lenalidomide, dexamethasone, had a superior PFS and OS. We have VTD, followed by transplants, showing a superior PFS. We have CyBorD, the original regimen described by the Mayo Clinic of bortezomib, cyclophosphamide, dexamethasone, showing a superior outcome. In the frontline therapy, you're well aware of the VMP, the VISTA trial, which was a European-based trial, VTP, the bortezomib, thalidomide, prednisone, and then there was the relatively small VMPT Italian trial. Phase 2 data shows 4 drug combinations, not using much 4 drug combinations, really not much more effective than 3 drug combinations, and have more toxicities. The hottest one, which we're going to talk about in a little bit, KRD, which is carfilzomib, lenalidomide, dexamethasone, at least in the U.S., and I'm surprised that Dr. Ludwig, although we talked about it over lunch, didn't talk about exasomib, which may be the future drug of choice for high-risk patients for maintenance therapy. It's the oral proteasome inhibitor. So we'll start off with a large trial done in Europe, VTD versus VCD. So we're comparing an immunomodulatory drug versus an alkylating agent with cyclophosphamide. And briefly, VTD had a superior complete remission rate and had an overall response rate that was superior compared to VCD. When they look at toxicities, actually the toxicities with the exception of neuropathy, which is expected with the thalidomide versus cyclophosphamide, was higher, but most of the other toxicities were actually fairly comparable comparing VTD versus VCD. And they concluded that VTD was a superior regimen. As it turns out, Mayo Clinic, which is the originator of the VCD regimen, is actually moving far away from using this combination because the immunomodulatory drugs do appear to be superior to the alkylating drugs. When you look at this SWOG trial, this has been presented by Dr. Jury at the last ASH meeting, compared VRD, bortezomib, lenalidomide, dexamethasone, on the bottom half with lenalidomide, dexamethasone. They found that the overall response rates of the VRD, 81% versus 71%, complete remission rates were twice as high, 16% versus 8%. So this also relatively large trial, 200 patients in each arm, showing the superiority of VRD versus RD. This translates into a hazard ratio of 0.72 or 43 months PFS versus 30 months PFS. And they also showed, still it's too early, but they actually have a p-value showing a superior overall survival with VRD versus RD in the frontline setting. This is a trial that was done and presented by Thanos Demopoulos. This was ICD, which is the oral proteasome inhibitor, exasomib, which is given 4 milligrams, days 1, 8, and 15 on a 28-day schedule. And then the trial was actually comparing 2 different doses of cyclophosphamide, 300 milligrams per meter squared or 400 milligrams per meter squared in the frontline setting. What they found was that the response rates appeared to actually be a little bit higher in the patients who had less cyclophosphamide. Small trial, I want to point that out. It's only 32 patients, but it looks like that you do not need to give a higher dose of cyclophosphamide. You can actually get by with a lower dose of cyclophosphamide and still get a good response. When you look at the variety of regimens that we have available to us, these are the older regimens. VAD is vincristine, adriamycin, dexamethasone. TD, which is thalidomide, dexamethasone. These are essentially never used in the U.S. at all. And then we have the combination, cyclophosphamide, bortezomib, dex, which we just discussed about, lenalidomide, bortezomib, dex, and this is cyclophosphamide, bortezomib, lenalidomide, dex. Response rates are essentially approaching 100% in these regimens. When you look at the depth of response, which is the CR rate, the CR rates also are relatively comparable. They exceed 40%. We're not to the point in any of these trials of minimal residual disease, which we're going to talk about in a little bit. Current frontline therapies, ongoing trials, both in Europe and the U.S., and I may have left 1 or 2 out because I didn't know about one that Dr. Ludwig told me about. Elotuzumab, the SLAM7 monoclonal antibody with lenalidomide dex versus lendex. They're all using lendex except for this trial. The first 3 are using lendex as their standard. Daratumumab, the anti-CD38 monoclonal antibody, which I'm certain is going to be discussed in detail later, with lenalidomide dex. Exasomib, which we just mentioned, the oral proteasome regimen. And then there are trials comparing directly carfilzomib and bortezomib in the frontline setting, both in the U.S., which is shown here, and in Europe, which is shown here, of carfilzomib melphalan-prednisone versus bortezomib melphalan-prednisone. Some of these trials are ongoing. Some of them are done, but have not read out yet. So we're moving from induction therapy to transplant. Should we transplant patients? If you can get a 100% response rate, if you can get a 40% complete remission rate, do you need a transplant? And the answer in my mind, which I'll hope to prove to you, is the answer is yes. So I'm going to show you 4 trials. One of them is very difficult to read. This was Antonio Palumbo's first trial, New England Journal of Medicine, 2 years ago. Everyone got lenalidomide dexamethasone. Then they were randomized to MPR, or actually tandem transplants with melphalan. And then there was a second randomization to maintenance with lenalidomide or not. So the biggest complaint about this trial is it didn't contain a proteasome inhibitor, either in induction, consolidation, or maintenance therapy. So that's one of the biggest issues with this trial. But what he shows here is that the high-dose melphalan had a superior outcome as far as progression-free survival and also in overall survival compared to those patients who did not have high-dose melphalan. So trial number 1 showing a superiority of melphalan as a consolidation versus MPR. And as it turns out, which I'm not going to talk about because Dr. Ludwig already did, the group that had the maintenance with lenalidomide also had a superior outcome. This is the second trial presented at ASH by Michel et al. Last December. In this trial, we're comparing early versus late transplant. So we have induction. Both arms get bortezomib, lenalidomide, dexamethasone. The upper arm in blue gets transplant, 1 transplant. They get 2 more cycles of VRD, and then everyone gets maintenance for 12 months. In the late transplant arm, VRD, stem cells are collected, VRD for 5 more cycles, and then it's followed by maintenance therapy. The U.S. is also joining this trial. The difference between the 2 trials is only in the maintenance. In the U.S. trial, this part is exactly the same. The French trial, they stopped maintenance at 12 months. The U.S. trial is continued until progression. The U.S. trial is not yet finished its accrual. It's not going to be presented at ASH. I assume that Dr. et al. Will update the French part of the trial at ASH of this year. What they found, was the overall response rates superior in the transplant group, 88% versus 78%. When they looked at MRD negativity, this is by flow, although I'm going to show you some next-generation sequencing. MRD negativity was also superior in the transplant groups versus non-transplant group. So depth of response, overall response, depth of response, superior in the group that had the transplant. When they look at the median progression-free survival, 43 months versus 34 months, again, the follow-up of this trial is not very long, and the hazard ratio was 0.69. When they looked at let's skip this one. The most recent trial was presented by Michele Cavo at ASCO. This is a European trial, a pan-European trial, and they compared early versus late transplant. So in this trial, they gave Cyborg-D, which I already told you is now out of favor, at least in the U.S., in the absence, using an immunomodulatory drug instead of cyclophosphamide. But they had 3 to 4 cycles of bortezomib, cyclophosphamide, dexamethasone. Everyone had their cells collected. Arm on the right had melphalan, and they could have 1 or 2 cycles of melphalan. It was up to each individual center if they wanted to do 1 or 2. It's an important point, which I'm going to come back to. The other group got standard bortezomib, melphalan, prednisone. So this is somewhat similar to the first one I showed you, except it was MPR. But in this particular trial, they get 2 cycles of 2 different regimens of Velcade, but then they have a second randomization to VRD. So half the patients are going to get an immunomodulatory drug as well as a proteasome inhibitor. So we have a randomization to transplant or no transplant, and then a randomization to consolidation or no consolidation. Everyone received lenalidomide maintenance therapy. This is the breakdown of the patients. Of note, which is really strange. When they looked at the high-risk group, it was almost half the patients. I'm not sure how that works. Maybe Dr. Ludwig could inform me how this broke out, but it was a very high-risk group overall. What they found was the group that had the transplant had the superior progression-free survival, not reached as far as the progression-free survival at the time of the analysis versus 44 months, which is actually quite good without a transplant. When they looked at PFS by cytogenetics, which is not surprising, The group that had standard risk cytogenetics had the superior outcome to the group that did not have that. And this is true particularly for the transplant group versus the non-transplant group. So PFS was, for the overall population, was superior. It was also superior in the high-risk group if they had the transplant incorporated into it. When they looked at the different populations, it showed across the board improvements. Again, we've talked a little bit about high-risk group. The ISS-3 in this particular trial did still show a superior outcome with transplant. When they looked at cytogenetic variations, the high risk as well as the standard risk, essentially all patient groups had superior outcomes with the transplant arm. The groups that did the best, which is not surprising if you had a complete remission, hazard ratio is 0.22, which is impressive. Standard risk was better than the high risk, and if you had a transplant, it was still 0.54. So this is a summary of the four trials. I didn't present this trial by Gay, which was published in Lancet Oncology, but these are all transplant versus no transplant, and all four studies show superior progression-free survival. The two older studies, the one from Palumbo and the one by Gay, show superior overall survival in the patients who had the transplant. So if one transplant's good, should we do two transplants? This has been investigated at a great deal by the Arkansas group, where I spent 6 years of my time with Dr. Bart Barlegi. But it wasn't until the IFM 94 and the Bologna 96 trials actually compared 1 versus 2. Those are 20 years ago that they showed those trials. And what they basically found was patients who did not achieve at least a very good partial remission were the patients who would benefit from a second transplant. So with all the drugs we have now that are very good partial remissions are well over 75%, it's still worthwhile to consider, should you do 1 or 2 transplants again? So there is two trials. I'm going to show you the data from one that look at 1 versus 2 with modern therapy, not what we had in 1994 or 1996. The first one is the European trial by Dr. Cavo. This is the 2 transplant group, 1 transplant group, no transplant group. 2 transplant group actually had the superior hazard ratio compared to 1 transplant. So it looks like 2 is superior to 1. This is not a randomized trial. This is just by dealer's choice. If you wanted 2 transplants, you could have them depending on the center. But it looks like 2 is better than 1 in this analysis. There is a very large U.S. trial which might read out as late-breaking abstract at ASH. I'm on the steering committee for this. It's 1 transplant for everybody. A third of the group, there's 250 patients in each arm. A third of the group get a second transplant. A third patients get VRD consolidation for 4 cycles. And the third group only gets 1 transplant with lenalidomide maintenance. And I'm hopeful that this is going to read out so we can actually again address 1 versus 2 transplants. Moving to depth of response. This is one of the hot areas in myeloma. This is our iceberg. You only see the top. You don't see the bottom. We need to get to the bottom or close to the bottom of the iceberg if we want to cure this disease. So this is some older data looking at MRD negativity. This is by flow cytometry. This is from the European group. And when they looked at the group with favorable cytogenetics, MRD negative, this reddish line had a superior progression-free survival and also had a superior overall survival. So it looks like the depth of response is very, very important for progression-free survival and overall survival. There are 3 different methods to look at minimal residual disease. There is 8-color, now it's 10-color flow, parametric cytometry, next-generation sequencing, and there's actually new criteria from the International Myeloma Working Group looking at radiographic complete remissions and minimal residual disease. All of these show that if they're negative, you have a better outcome in PFS. This is looking at both immunophenotyping and by next-generation sequencing, by molecular testing. And as you can see here, for those who are in immunophenotypic complete remission, superior outcome. And if you're in a molecular complete remission, superior outcome. So depth of response appears, again, to be very important. So when we look at another study looking at transplant or no transplant with depth of response, the other trials, there's two trials that look at this. I'm going to show you both of them. This is by Dr. Jakubowiak. This is using the regimen which is most common in the U.S. And in this trial, they gave carfilzomib Revdex, and this group over here on the left did not have a transplant. They got consolidation with KRD, and they stayed on KRD maintenance. The second group, these are two parallel trials. This is not a randomized trial. It's two parallel trials being done, actually not at the same time. This trial was done first, this trial was done second. He's comparing these, which isn't quite the way it should be done. KRD plus transplant, KRD consolidation, KRD maintenance, and everyone end up after 2 years on lenalidomide maintenance. What he found was the group that had, let's skip that, the group that had the yellow line is the KRD with transplant, progression-free survival was superior, overall survival too soon to tell. MRD analysis, when they looked at flow cytometry, this is the group that had the transplants, 100% versus 51%. When they looked at next generation sequencing, 75% versus 24%. So yes, you can get complete remissions. You can get MRD negativity without a transplant, but the likelihood of achieving that, at least by flow cytometry, is double and almost triple if you have a transplant sandwiched in between the KRD regimen. So let's skip that. The IFM, the 2009 trial, which I already showed you the data, actually looked at MRD negative, MRD positive patients. And to make a long story short, the patients who are MRD negative with or without the transplant actually did the same. So let me repeat that. If you had a transplant or did not have a transplant, if you were MRD negative, your outcomes were very good. However, the likelihood of being MRD negative was twice as high in the transplant group. So that raises the question, if you achieve MRD negativity, do you need a transplant? And I don't know the answer to that yet, but that is the question. And because we're running late, let me just skip this. This is looking at MRIs and PET MRD negativity. So this is MRI negative patients, the progression-free survival versus MRI positive patients. This is PET negative versus PET positive, both showing a superior progression-free survival. Overall survival, too soon to see if there's going to be a difference. So you can look at MRD negativity with radiographic testing. And this just was published in Leukemia by Saji Kumar, looking at MRD negativity using radiographic evaluations and by, that paper has been submitted. This is looking at MRD, the definitions for MRD negativity using either flow cytometry or with next generation sequencing. There is a paper coming out on MRD negativity using PETs and MRIs. So, role of MRD testing remains a research tool. I don't know if we should keep treating patients with different regimen after regimen after regimen to achieve MRD negativity. We don't know that yet. I know if they get there, it's better, but I don't know if I should use up all my drugs to achieve that level of disease response. It certainly contributes to definition response. You can monitor the efficacy of therapy. We don't know how long or how often we should measure MRD negativity. It's kind of a new thing. The easiest way is by Euroflow, which is a 10-parameter flow cytometric analysis. This is done on bone marrow. The next generation sequencing is still being done on bone marrows. Ultimately, I think MRD testing may be applied to tumor-free DNA in peripheral blood, which would save us all doing bone marrows. Not quite there yet. Patients who achieve MRD negativity still can relapse. The high-risk patients, even if they're MRD negative, still relapse well before patients that do not have high-risk disease. And finally, I want to just conclude with a couple comments. This is a stratification from the Mayo Clinic, from this MSMART. Everyone still agrees 17p deletion, 1416, 1420, and gene expression profiling is high risk. 414 used to be in the high risk, but with the use of proteasome inhibitors, it's now intermediate risk. The one I want to talk about is new data that just came out on 1114, which used to be considered standard risk myeloma. This is a paper that was just published in Leukemia by the Mayo Clinic group, and what they found is that patients with 414 had a worse overall survival than those patients who did not have, this is the 1114 here, had a worse outcome compared to those who did not have the 1114 translocation. This was true for when you were stage 1 or 2, but if you were stage 3, it was a wash. Stage 3 still was bad whether you were 1114 or not. So 1114, which is a new finding, it was about 78 patients in their paper, does have prognostic implications, not to be considered standard risk anymore. Probably they're putting it, they're going to modify that, they're going to put it in the intermediate risk group. So this is what happens if you give a bortezomib-based therapy. Standard risk patients here, 1114s are better with bortezomib-based therapy, and the high-risk side genetics, for the most part, even the 17Ps in their trial, still have a dismal outcome. When they look at the hazard risk ratio, high-risk FISH is 1.6, stage 3 is 1.3. If you get maintenance therapy, 0.6, showing that it's still higher. And here's the 1114, 78 patients had a worse progression-free survival and also an overall survival. Dr. Ludwig already presented this data. I'm not going to go over that. This is the consensus from the International Myeloma Working Group. Thalidomide does not help adverse side genetics. In fact, Dr. Ludwig showed you in the high-risk group, they do worse. Lenalidomide doesn't really help much with the high-risk group, although pomalidomide may help the high-risk patients. Bortezomib can partially offset the effects of 414, and at least in one trial, the HOVON trial, of 17p. There depends, if you have a combination of 17p and 414, you have a pretty dismal prognosis. VMP may also, because it's a bortezomib-based regimen, may help with the adverse fit outcomes. Lenalidomide really doesn't do much in the high-risk group, but pomalidomide, based on the data from Demopolis in the pomalidomide DEX trial, showed that the 17Ps actually had a better outcome with the pomalidomide than they've shown with the lenalidomide. Transplant standard of care. Double transplant may improve patients with high-risk disease, shown in the HOVON trial and also in the European trial. We still should consider doing transplant in the high-risk group. I would actually recommend doing 2 transplants followed by maintenance therapy. Allotransplant, which I'm not going to talk about, still is considered to be investigational. There's a large U.S. trial undergoing allotransplant with they're using exasumib with, maintenance or no maintenance with exasumib after an allotransplant. This is just an outline from the Mayo Clinic, not promoting this over anything else. What they had called the standard risk group, which we now have to get the 1114 out, they recommend VRD induction, stem cells, transplant is preferred, otherwise more VRD consolidation, and then maintenance therapy. Intermediate risk group, VRD, transplant, consider tandem transplant, and then a proteasome-based maintenance therapy. High risk group, KRD, carfilzomib Revdex, transplant, again considers tandem transplant, followed by a proteasome-based maintenance therapy in transplant-eligible patients. In the non-transplant eligible patients, it's a much simpler algorithm. VRD, standard therapy based on the SWOG trial, which was tolerated in patients that were included a good proportion that were older than 70 and 75, followed by RD for a year. The 414s, VRD for 12 months. This is, again, their opinions. This is not evidence-based, followed by bortezomib maintenance. And the high-risk VRD followed by a bortezomib maintenance therapy is their current recommendations. And with that, I will end. Thank you.